Good afternoon, and thank you all for coming out on this lovely day. We hope we're going to have a session where we'll be inspired and learn about some exciting new developments and resources in Edmonton. My name is Kate Quinn, and I'm the chair of the Edmonton Sexual Exploitation Working Group. And we've been offering these Lunch and Learn series over this past year with the theme, the role, pathways in and out of sexual exploitation. The role of. So in the fall, we had the role of housing. In January, the role of fetal alcohol syndrome. And now, today, we're going to focus on mental health addictions and health resources. And we're excited about today because we're going to be able to share some great knowledge about how our Edmonton community is continuing to listen, learn, and add new resources that will truly be helpful to people. I'd like to respectfully remember that we are on the traditional territories of those who are of the Cree, Dene, Saulteaux, Blackfoot, Nakota, Sioux, Métis, and Inuit heritage, and that we are all working together as treaty people, no matter what our heritage is, to create pathways forward for truth and reconciliation in our land. Before you, you'll see this orange scarf, and there's a little light just barely flickering safely. And many of us on the Sioux committee are wearing shades of orange. And we have chosen orange as our color because it's internationally recognized as a color by many who are working for liberation and to end sexual exploitation and human trafficking around the world. We also always want to remind ourselves and carry within us the memory of those whose lives have been stolen from them through sexual exploitation, whether by murder or by suicide or by the effects of trauma and addictions and the impact on physical health. So I invite you all just to carry people that you probably know within your heart throughout this session. I will briefly introduce you to the partners of the Sexual Exploitation Working Group, and I'll just call out the name of the organization, and if anyone is here, just wave your hand. So ACT Alberta, Alberta Health Services, Addictions and Mental Health, we have a couple of our guests, Bent Arrow Traditional Healing Society, CEASE Center, yay, CEASE Center to End All Sexual Exploitation, Edmonton Region Children's Services, PSECA, that means Protection of Sexually Exploited Children, Edmonton Fetal Alcohol Network, City of Edmonton Citizen Services, Edmonton Police Services Human Trafficking and Exploitation Unit, REACH Edmonton Council for Safe Communities, the Sexual Assault Center of Edmonton, and the Family Center. We also have an elder who accompanies us, that's Gloria Laird. Sorry. REACH is our backbone organization as our kind of the mobilizer around community safety in Edmonton. And as such, we really want to thank REACH and the Collaborative Media Group, the folks at the back who are filming this and making it possible for people to sit at their desks and watch this over lunch. As well, on Monday, you'll be able to spread the word that this webcast will be up on the REACH YouTube channel. When you came in, you were given cards. If you have any questions, just mark them down and send them along the line. We'll have some of our SUG members collecting them, and then I will kind of coordinate the question period. We'll give the most of the time to our two excellent speakers, and then if you have to slip away right at 1, that's fine, and then we'll have questions from that 1 to 1:30 period. Great. So our first presenter is Kimberly Poon. She graduated from the University of Alberta with a BSc in nursing and an MA in business admin, and specializing in public policy and management. Over the past 15 years, she has worked in various healthcare settings, including neurosciences, trauma, medical, surgical, community health, and liver transplant research. She was also a nurse educator with the Boyle Street Community Services. And after this work in the inner city, Kimberly moved to Alberta Health Services Mental Health and Addictions. And she's helped to lead several acute and community-based programs. She's also served on the Alberta Community Council on HIV, Edmonton Social Planning Council Board of Directors, and Emerging Health Leaders Executive. Currently, Kim is the project lead for the new initiative, Access 24/7 Addiction and Mental Health. Welcome, Kimberly.
Great. Thanks, Kate, and good afternoon, everyone. So I'm going to take you guys through a presentation about Access 24/7 and what you can expect when we open, and kind of the journey that Alberta Health Services Addiction and Mental Health has taken to get to this point. Let me just adjust the mic here. Okay, so I want you guys to picture something or imagine something for a moment before I get into the presentation. So imagine you're at a lake and you're with your family at this lake. So it's, you know, it's summer, you're at the lake. One of your family members is out swimming in the lake, and you suddenly begin to notice that your family member looks like they're having problems keeping their head above the water. So you start to panic, although you see that there's several lifeguards around, so you're hopeful that somebody will come and help you. So you go to the first lifeguard. The first lifeguard says to you, you know what, I don't work with people within that age range. You're going to have to go to the next lifeguard. The next lifeguard says to you, this is lifeguard number 2 now, that's not my section of the lake. You're going to have to go to the next lifeguard because I only take care of this section. So by this time, you're really starting to panic because you see that your family member is struggling. The third lifeguard says to you, well, will you need a raft, a boat? Will they need CPR? I need to know what they need before I know if I can help you. And then the fourth lifeguard says to you, sorry, I can only help people who have fallen out of boats, not the people who have swam too far away from the shore. Finally, the fifth lifeguard says to you, you know what, I can only help people who ask for help themselves. So I have a form. If you could get your family member to sign this, then we can help you. So this kind of analogy or comparison to accessing addiction and mental health services in Edmonton was written by a man who is living with an adult son who has been experiencing schizophrenia. And it is by this man blogs as a form of coping with his son's illness. And so that was basically how he tried to outline what it's like reaching out for help for his son. And that was by an advocacy group. He's with an advocacy group called Families of Adults with Mental Illness. So if anyone's interested or looking for family support, that's a great advocacy group. So next, I'm going to tell you a little bit more about the current state of access to addiction and mental health services in the province. So over the last several years, there have been many provincial reports done. We've had the Auditor General come around and take a look at our system to see what we needed to improve. We've also had Dr. Cam Wild from the University of Alberta School of Public Health complete a province-wide review of our system. And then most recently, our government had completed a valuing mental health report with several recommendations. So over the past several years, we've known now and we've been told that we really need to improve access to services for those experiencing addiction and mental health. So in the Edmonton zone, what you guys see up there is a map of all of the services offered by AHS and Covenant Health Addiction and Mental Health. You'll see that basically we offer services all the way up in Morinville, St. Albert, all the way down to Leduc, and from Sherwood Park all the way to Stony Plain, Spruce Grove. So with all of these different access points, it can be really difficult for family members or people who are experiencing mental illness to try and find which service is right for them. So oftentimes we hear that there is also a gap in services after hours. So if someone is in crisis and it's the weekend or maybe it's an evening, the only place that you can really go is to an emergency department. And then we know that for those people presenting to an emergency department with an addiction and or mental health concern, about 80% of them are actually discharged back into the community. So that kind of leaves people at, their own will, trying to figure out what do they need. What we're saying to the public by only offering services within that time frame and only looking at emergency services after hours is if you're not in a crisis, there's no one there to help you. So back in about 2017, 2018, we took a look at some of our programs that are all operated within AHS. So some of our programs that kind of focus on entry point into our system. And we had an idea. Our idea was to potentially bring all of these programs together under one roof and offer 24/7 services access to our system. So in moving forward with planning, back in 2017, in the fall, I started out by doing broad stakeholder consultation across the city and surrounding areas. So basically what we did was ask people 4 questions. 1, what was their experience like in accessing addiction and mental health services? 2, what were the barriers experienced by them? 3, what would be important to people as we move forward with our stakeholders, patients, and families as we move forward with this initiative? And then 4, what was working well within the system and what should we keep as we move forward with this transformation? So yeah, we met with over 400 people from patients, clients, and families to staff members, physicians within addiction and mental health. We went outside of addiction and mental health and also met with other parts of the health system, like the primary care networks, Fort Saskatchewan Correctional Centre, the Remand Correctional Centre. We met with all of the emergency departments in the zone, including like Devon Hospital, Strathcona Community Hospital, so very large consultation, the Indigenous Wellness Program, and then we even took it a step further and had held several working groups with places like EPS, the Norwood Child and Family Resource Center, Salvation Army, Boyle Street, the Bissell Center, WEAC, many of the not-for-profit agencies that we work with. And we collected all of their feedback. So I'm going to share with you some of the themes that we heard from our stakeholders when we went through this consultation. So definitely, everyone's feedback confirmed that our services are fragmented, complex, and very uncoordinated. Our own staff said to us, if we don't understand our system, then how can we expect patients to understand? Our clients said to us, and our partners in the community said to us, you know, you guys only call yourselves addiction and mental health, but that's not actually how it feels when we try to access your services. So I show up at, say, the addictions clinic downtown, but I'm turned away because I have a primary issue of depression. So I'm told to go to a different clinic. So although we call ourselves addiction and mental health, that's not how our system behaves. We also heard from our community partners that each program wants something very different, in that, you know, the program out in Sherwood Park is very different than the program out in Edmonton, and so there's so many different programs and services available, but it's hard to make a referral on behalf of a client that a community agency is working with if they don't know what's offered. Sorry, the mic's in the way. A client, so I met with a client group with the Schizophrenia Society of Alberta, and so their feedback to us was, you know, your system's really good at keeping people from dying. As well, and this is what I mentioned before, that there's really no services after hours unless you're in a mental health crisis, and typically that's the emergency department. One thing that we heard from our community partners was that AHS Addiction and Mental Health feels like all we do is put up barriers, when some of the agencies like Boyle Street and Bissell literally have no barriers at all in accessing their services. We also heard from our patients saying that, you know, sometimes stigma, discrimination, and fear could be a barrier to accessing services, as well as things like parking, transportation, and access to a phone. We heard a larger theme around, you know, people need to fit into our system rather than the system adapting to what the need of the individual is. So a family member said to me in one of the focus groups that, you know, it feels like people just need to be right, just right to get into the system. So either you're too sick to get into the system or you're not sick enough. A client said to me that sometimes it feels like you need to attempt suicide in order to get help. We also heard that access is not equitable because there are so many different ways to access our system. It's hard to know and triage who really needs the services first. So, and the other piece that we know of as well is that access to our services is based on relationships. So, say there might be a family doctor who knows a specific psychiatrist out in the community under our services. Because they have that relationship, the patient would get in to see that psychiatrist. There is no in between to also look at other patients who might also need a psychiatrist who don't have that relationship, or their physician doesn't have that relationship. And then, of course, the system lacks transparency. We heard very loud and clear from our stakeholders, particularly our community agencies, that, the system feels very secretive. It's hard to know what the wait times are, those sorts of things, what the criteria are for different programs and services that we offer. Okay. So after doing that consultation, it took about 6 months to meet with everyone and collect their feedback. We took a bit of a step back to say, okay, we have all this feedback from our stakeholders. We've done a great job, I think, with consultation. We've had these provincial reports kind of mandating Alberta Health Services to improve their services. We also took a look at across Canada and within North America, the different systems that kind of promote a centralized access sort of model. So we looked at some peer-reviewed scientific research, as well as different reports that various health systems like in Ontario and BC, where they've reviewed their system and what they're doing to implement a new access shift. So our group, our steering committee, so that's basically some of our senior leadership within addiction and mental health, came up with the following principles. And the one that I always like to highlight when I'm out talking to people is really that we need to work with the principle that whatever is happening within our system, it really needs to be invisible to those who are accessing it. So you shouldn't feel, as someone trying to access our services, all of the bureaucracy and red tape that goes into, and processes that go into matching you to the right service. So primary principle is system complexities will be invisible to people who are trying to access our services. And we came forward with a strategy as well. So our Access 24/7 will be open 24/7. And all of those different clinics that you saw on that map, Access 24/7 staff will have access to basically admit and schedule into any of those programs. So it would be one central point people would contact, and then we would match them to the right service within Alberta Health Services or Covenant Health. So what next? So given all of that consultation work and the work going into reviewing other systems and developing some core principles and strategies around the project, we took a look at, within addiction and mental health, in the Edmonton zone, that's in red there, we have over 2,600 frontline staff that vary from social work, occupational therapists, peer support workers, family peer support workers, nurses, physicians, I'm probably missing some, like psychology, as well as we have over 225 psychiatrists that provide services, and much over 120 programs and services. So how could we better reform the system to make it easier for patients and families to try to access services? So our vision is to offer a front door location at Anderson Hall. So if you guys aren't familiar where Anderson Hall is, it's right across the street from the Royal Alex Emergency Department. And basically there has been multiple programs that have been kind of co-located to provide this 24/7 service. We're basically going to be operating a telephone support, in-person assessment, so people can walk in anytime 24/7, as well as our crisis and stabilization services will be there. So with that being said, if someone lives in Sherwood Park and they walk into the clinic at Sherwood Park, then they should be welcomed into that clinic and not be told, oh, well, you need to drive all the way to the Royal Alec to get some assistance. So although we're centralizing, we're also making sure that anyone who presents at any of the other areas are still welcomed, and their experience in accessing services is exactly the same as it would be if they, say, went to Leduc or Anderson Hall. So we created a governance framework. I'm not going to spend a lot of time on this, but basically there are so many people and programs outside of addiction and mental health that are part of our system, right? So we really needed to bring together our emergency partners. So we brought together frontline and managers and physicians from all of the emergency departments across the zone to really look at what's the difference between Anderson Hall or Access 24/7 versus going to an emergency department, and how would we figure out what that pathway looks like. As well, we have an engagement working group that has, patients, families, peer support workers, part of the engagement working group, who helped us to develop, if we could repurpose the front door area and the space in front of Anderson Hall, what would that look like and what would make sense? Our engagement working group also gave us a lot of really good recommendations about if you're going to integrate peer support, these are the skills that you should be looking for at that front door. So there's that group, and then as well as we really needed to figure out how Access 24/7 would interact with the various inpatient psychiatric units across the zone. And so we have units in 5 different hospitals, so we really needed to bring them together, and we held multiple working group meetings about, if someone's being discharged from hospital, what's Access 24/7's role in connecting them to the community resources. As well as EPS, we need to figure out, is it appropriate for EPS to bring patients who might be under the Mental Health Act into Anderson Hall versus an emergency department? And as well as EMS. Would there ever be a time when EMS decides that it would be appropriate to bring someone from the street, say for example, to Anderson Hall versus an emergency department? So at Access 24/7, those are the different services that will be offered. So like I said, our crisis team, our crisis response and emergency medical services, so that's our what we call CREMS, our partnership with EMS. We also will have our police and crisis team located out of there. As well as our stabilization, which is kind of like a short-term stabilization provided in the community for clients who might need something in between while they're waiting for other services. As well as we have an urgent psychiatric clinic, so we will have access to psychiatry 12 hours a day, 7 days a week, who will provide an assessment and consultation should a patient require that type of service. And then, of course, our intake team. So about 6 months ago, we have an intake team that's located at our main downtown clinic at 108th Street. And so they're the ones who receive all the referrals from other areas. They've also moved to Anderson Hall. So I've also listed out there the different staff that will be working at Access 24/7. Basically anyone can contact Access, whether or not you work for a community organization and you have a client that you think would need further services, contact Access, or if you just want help about how to navigate to the right place, call us. If there's someone in crisis, you're going to call us. Family members, we will have family peer support workers as well to work with family members who are struggling with those with addiction and mental health issues. We will offer information and referral, supporting individuals to help navigate. There will also be that consultation and assessment from our psychiatrists. We haven't figured out yet what type of groups we will offer from Access 24/7 because we don't know what the demand will be like at that front door and as well as on the phones. So probably, we don't know when we're going to open yet. It's probably in the next month or so. But once we're open for a couple of months and we figure out what the call volume's like, what the demand is like at the front door, then we'll be able to look at offering other services when people walk in, as well as our crisis team, like I said, will be working out of there. So Anderson Hall, that's what the front of the building looks like. We are on site on the main floor. That's where the walk-in area is, as well as the clinic space, so patients and families will be seen there. On the 5th floor, where we have our call center there, as well as our outreach teams, like our police and crisis and CREMS, work out of there, and that's kind of their touchdown space. The really cool part about being at Anderson Hall is we're in the same building as the Indigenous Wellness Program, so I think that there's definitely opportunities for collaboration. We know that there's prevalence of mental health and addiction within that Indigenous population. So we're hoping that, we'll be able to work together with them. And that's just another picture of the front. So there's actually, we're hoping to get some funds to actually make it look more welcoming. We were only given enough funds to repurpose the space. And so if you were to go to Anderson Hall, you kind of would be able to notice, because it used to be a residence, you would be able to notice that the different rooms are like individual apartment suites. So we're hoping down the road, as we evolve, that we'll actually hopefully get like a permanent space that we can actually purpose develop. And then this is where Anderson Hall is located. It's that red dot on the map there, so just across from the emergency department. So right now, what's happening, like I said, we don't know yet when we're going to be open. We've had to recruit, we've had a large number of vacancies, I think up to 20 positions where we were recruiting mental health therapists. And so it's been really hard to figure out, when can you actually open the front door and provide a safe environment for both the patients and staff. So that's yet to be determined. Basically, what's happening in the Edmonton zone with all those clinics that you saw on the map is we're slowly taking on all of the phone calls for services, their fax referrals, any discharges from hospital, GPs who might refer to some of the clinics. Those will all be centralized to Access 24/7. We're also working on our electronic medical record to make sure that we do have that scheduling and admissions authority into the programs that you saw on the map. We're also embedding a state-of-the-art call center software. So AHS has adopted the use of this call center software, and we're going to be the first clinical program to actually use it in practice. And what that means is we'll be able to, if pretend you're working in a call center. As a clinician, you'll be able to see all of the incoming calls, how many people are waiting. We'll be able to record the calls so that we can do some quality with the clinicians, and then as well as figuring out different metrics like how many times did people hang up because they waited too long and those sorts of things. So with all of the programs that have moved to Anderson Hall, there is significant cross-training and education that needs to happen. So what the teams were before was our intake team and say our crisis and stabilization program. But those two teams need to merge and be able to do the intake role and the crisis role. And that is it's a huge change for the staff. So it takes some time to train them to get everyone on the same page. The other piece that can't be understated is, although we're fixing the front door to addiction and mental health services, there's still all the programs that have long wait times. So although we can fix access at the very front, there's still a lot of work in the system that we continue to challenge for that to be more streamlined as well. So construction and renovations are almost, I think they're complete now. Our teams have been there since January 4th. And again, we're going to be open in the next couple of months. I don't have a date yet. So as far as what will happen or what people can expect when calling Access 24/7, there'll be screening, triage, and assessment done by a clinician. So we'll have peer support, family peer support, admin staff, but anyone who walks in will be seen by a clinician for further screening, triage, and assessment. We're going to then match their needs, their presenting needs, to the various services that might be available on site at Access 24/7, as well as we anticipate there will be people walking in that might need an emergency department visit or police or ambulance as well. We know that there might be some individuals that might require an inpatient admission, so we need to be prepared for that, as well as matching people to the different community and programs offered in the zone. And then working closely with our agencies, organizations, and places like primary care. So what we're doing, because it's really hard, if you can imagine, for an intake clinician to be able to know about all the services available in the entire zone, is we're actually developing what's called a service matching database, and we're implementing a decision support tool to figure out how to match people appropriately to the right service. And so that tool, if you're interested in learning more about it, it's called the Level of Care Psychiatric Utilization System, and it's been implemented across parts of the US, and then in Ontario and in BC as well within their addiction and mental health systems. So basically it basically takes your assessment findings as a clinician and provides a level of care recommendation around what sort of programming would best meet your needs. So the last thing I want to say is that, and I kind of touched on it before, is that although we're opening a center that will give quicker access or access to services, will help navigate and make things less confusing, there are many entrenched practices kind of beyond that door that we continue to challenge. So everything from how we provide services, who we see, our wait times, how we do things internally, that's also being challenged constantly. The other piece of it is that, we purposely involved patients and families in the planning because we want to make sure every decision, no matter how small or large of an impact it has, that we're actually involving them and giving them a meaningful opportunity to use their voice. And then, of course, I always like to say this too, we're not going to get it right the first time. I think when we open our doors, we hope that our community providers will understand that this is a huge effort on our part. And so hopefully the experiences will all be positive, but understand that we're not going to get it right the first time. So this is just a quick video. I don't think we have audio, do we, for the video? No? Okay. Well, if you guys are interested, the Royal Alex Hospital Foundation has, and the Mental Health Foundation have done a significant campaign called #OneDoorYEG. So if you were to search the #OneDoorYEG, you would find some videos and promotional material about Access 24/7. And then I think we're going to leave questions till later, and I will pass it back to Kate. Thank you.
Thank you, Kimberly. It's certainly, again, being rooted in listening and then bringing together all these great minds to plan, and you're moving a big system to coordinate it, and we'll be patient. It's going to be good for our community and for people. So next I'd like to welcome Megan Aktimachuk. She graduated from the University of Alberta with a BSc in nursing in 2008. She's primarily spent her career working in intensive care at the Royal Alexandra Hospital. And during that time, she was introduced to another wonderful gem at the Royal Alex, the ARCH team, which stands for Addictions, Recovery, and Community Health. So after seeing the effects of addiction and stigma, she wanted to make a difference in the lives of people who are vulnerable. She began working with the ARCH team at the Supervised Consumption Service at the Royal Alex in just April of 2018, and recently took on the role of clinical nurse educator for the ARCH team in December of 2018. So welcome, Megan.
All right, so thank you for the thank you for having me and for the introduction. So I am quite new to this role, so bear with me, I'm a little nervous today, but I'll try to answer any questions and things that you guys may have. So I've been asked to just talk about the addiction recovery and community health team at the Royal Alex, and just recently we've expanded our services into the emergency department at the Royal Alexandra Hospital. So I'm just going to talk a little bit about that. So let's talk about a little bit about the opioid crisis, a bit about harm reduction, and then, and then the the reasoning for our expansion into emergency departments and how emergency departments can help on the front line with the opioid crisis. So the opioid crisis in Canada has been declared a public health emergency. In 2017, there were almost 4,000 apparent opioid-related deaths. 92 of those were accidental or unintentional, and 72 of those involved fentanyl or fentanyl analogs, compared to only 55% in 2016. So this is just a picture to highlight a comparison between like a carfentanil, and a heroin lethal doses. So as you can see, the fentanyl and carfentanil, you need very small amounts, like grains of sugar, salt, it looks like. So a lot of drug dealers are lacing everything with the fentanyl and carfentanil. It's more addictive than many drugs. It's easy to sneak into the country, and it's also very profitable for them. So that's kind of leading to part of the opioid crisis. And then also they're making opioid drugs in the same labs that are making stimulants or crystal meth and cocaine and things like that. So there's cross-contamination. So kind of traditionally, our way of dealing with the drug problem was to kind of put people in jail and kind of say, oh, it's a moral failing on your part that you're addicted to drugs. You need to hit rock bottom before you can seek out treatment, that sort of idea. And that's been shown to not be very effective. So a newer approach is called harm reduction. So it's activities or programs undertaken to decrease the risk of injury or harm associated with substance use or other high-risk activities without requiring abstinence or cessation of that activity necessarily. So it is evidence-based, backed by science, and it focuses on the harms from the drug use rather than the use itself. And it also, at its core, engages and involves the people who actually use the illicit substances. So some examples are that you may or may not think of too are like seatbelt and helmet laws, nicotine replacement products like the patch and gum, filtered cigarettes, sexual education programs in schools, opioid agonist treatment options, distribution of free injection supplies and condoms, supervised consumption services, and then like healthy school snack programs. So substance use occurs along a continuum from no use to beneficial use, and then to recreational use, and then it gets riskier as you go on. So it goes to binge abuse and substance use disorder. A substance use disorder is actually included in the DSM-5, so it's classified as a mental illness. Harm reduction strategies meet a person wherever they're at along this continuum in their motivation to change. And the continuum's not linear. So sometimes people can have periods of abstinence and then they'll have a relapse and start using substances again. And they can move back and forth on that continuum. So just like this definition of opioid use disorder, it's a chronic illness characterized by periods of remission and relapse, with addiction being the most severe chronic stage of a substance use disorder. And therefore, just like any other chronic disease, you're going to need treatment, and often you may need treatment for life. So that's like opiate agonist treatments are one of the ways we treat opiate use disorder, and that's giving long-acting opioids to patients who've been diagnosed with an opioid use disorder as a safer alternative to consuming illicit opioids. They reduce cravings, illicit use, and withdrawal symptoms. And again, like any other medication for chronic illness, you may need to take them for a long time or life. And examples that you might have heard of are methadone and buprenorphine or naloxone. It's also called Suboxone. This is just an article highlighting kind of emergency departments and their reasoning to kind of be at the front line of the opioid crisis and how they can help. So like in the ER, we treat many chronic illnesses. So like hypertension, diabetes, COPD, they start on meds, do referrals. So why not for opioid use disorder and opioid agonist treatment? So these are kind of just this table lists some of the kind of perceived or actual barriers that have been in the past for starting opioid agonist treatment in the emergency department. So one of the concerns, like addiction is a moral failing. patients may keep coming back to the ED time and time and again. Again, it's not a moral failing, it's a chronic relapsing disease and patients need treatment for. Providing buprenorphine to patients will lead to diversion, and this actually hasn't been shown. Actually, patients seek out illicit buprenorphine. They buy it on the street to try and treat their withdrawal themselves. And initiating buprenorphine treatment is complicated, and the ED is already crowded and chaotic. Well, it's actually safer and more predictable than a lot of medications that are started in the ED. And treatment can be accomplished in less time than an urgent care visit. Initiating buprenorphine will increase length of stay. It actually reduces length of stay. A lack of referral sites for patients who've initiated buprenorphine treatment. Most communities do have treatment resources and in the community, just the ED may not be aware of these, and that's part of Kim's presentation too, is just trying to create more awareness about these services and more centralized access. Patients will return repeatedly for redosing, and that's not been demonstrated either. If you actually loop people into community resources, they'll go there. Patients will flock to the ED for treatment. Again, patients with opioid use disorder are already in the emergency department looking for treatment. They're in bad withdrawal and they're showing up trying to get help. Many patients don't want treatment anyway. So some patients after overdose especially are not ready. So even if you have a discussion once in the emergency department, even putting that bug in their ear and being offered that one time, maybe next time they'll be ready. So it's studies have also shown that the more you talk about it, people will come back and request those treatments maybe the third or fourth time even. And then this is more for the US, but there is special training that is required to prescribe buprenorphine and Suboxone and methadone. So the national guidelines have kind of been lifted a little bit, but the provincial guidelines in Canada is still a little bit of a process for prescribing, so trying to work on that sort of thing too. So opioid agonist treatment in the emergency department. So some of the other real or perceived barriers is again, I've talked about this just right now, but methadone, again, traditionally needed a special exemption from Health Canada, and that federal restrictions removed as of May 2018, but then there are still barriers at the provincial level. There's still a lot of lack of knowledge about prescribing any opioid agonist treatment options. Opioid agonist treatment isn't covered by any drug plan except for emergency drug coverage, so a lot of patients don't have the financial resources, so you do have to make sure they're able to afford covering it, but it is still cheaper than using illicit substances, so a lot of patients are happy to cover the cost. It's cheaper than going to the street and buying drugs. And there's also the diversion worry. Traditionally, a person experiencing opioid withdrawal presenting to the emergency department would be given treatment for their symptoms and discharged with no follow-up, despite the existence of opioid agonist therapy and evidence-based therapy, and there's no follow-up or no treatment for the underlying opioid use disorder. So we're really trying to change that by being in the emergency department. So again, this one study found that only 1 in 3 patients received medication for opioid use disorder, and roughly 5% died in 1 year. Opioid-related mortality and all-cause mortality were actually lower among patients who received buprenorphine or methadone. Patients who were assigned a brief psychosocial intervention and started on buprenorphine in the ED were linked to continued treatment, were twice as likely to be engaged in formal addiction treatment still at 30 days after. So again, just the ED is a great time to engage people and really discuss these options and really try to help people. And evidence-based treatment shouldn't be easier to obtain in the community than in a hospital setting. So who is ARCH? So we're the Addictions Recovery and Community Health Team at the Royal Alexandra Hospital. It's part of the Inner City Health and Wellness Program. So I had a poster, but there's no way to put it up, so I'll just kind of describe it. So there's 3 branches to the Inner City Health and Wellness Program. So the Addictions Recovery and Community Health Team, or ARCH, is the clinical branch. So we see patients, inpatients. We see patients in a clinic now and in the emergency department. It's a multidisciplinary team, consists of physicians, nurse practitioners, addictions counselors, social workers. We have a pharmacist, peer support workers, and now we have registered nurses and licensed practical nurses as well working in our supervised consumption service. And we provide comprehensive evidence-based addiction management, and it's rooted in a harm reduction philosophy and approach. The other 2 branches of the Inner City Health and Wellness team are of an education branch. So we do a Inner City Health and Wellness Symposium every year in January on a variety of topics. And then there's also a research branch. So we have an embedded research team right at the Royal Alexandra Hospital. It's in the basement, which is great. We can get like real-time data and evidence for like our initiatives, which is very unique and awesome for us. So on the inpatient care side, so ARCH does treatment of complicated intoxication or withdrawal, initiation and maintenance of opioid agonist treatment, harm reduction, including distribution of opioid response kits. We have the supervised consumption service that just opened in April of last year, and it's the first in-hospital supervised consumption service in North America. We have a managed alcohol program, and just recently in October started injectable opioid agonist treatment. So that would be for people who've traditionally not been able to stop illicit use or are still using quite a bit illicitly on top of oral opioid agonist treatment or traditional therapy. So we will try them on injectable opioid agonist therapy. It's a prescribed dose of Dilaudid. It's prepared by pharmacy. It's sterile. It's sent up to the supervised consumption site, and people are directly observed to inject that. It's kind of like if you had pneumonia and you weren't able to get rid of it with oral antibiotics, we'd switch you to IV antibiotics. ARCH also does management of coexisting substance use disorders, health promotion, and a big one is social stabilization as well. From January 1st, 2017 to December 30th of 2018, we've had 3,475 unique consults, and they've seen 2,408 patients. This is just some pictures of some of the stuff we have. So the bottom 2 are of the supervised consumption service. It actually is on a pre-existing unit at the Royal Alexandra Hospital, so just kind of like Anderson Hall, it does look, all our rooms kind of look still like patient rooms, but the one on the right there is our consumption booth, and you can see the sharps container there, so people can come in. It's a clean, sterile space, well-lit space. You have time, staffed by 1 RN and 2 LPNs. There's immediate overdose response there if something did happen. That's our post-consumption room is the other picture on the bottom, so you have recliners, and people can just kind of relax and watch TV and have a snack and be monitored in a relaxing, non-threatening kind of environment. We work a lot to work on rapport with patients while they're there. The other picture on top is just some of the supplies we give out in the supervised consumption site, and then what our managed alcohol doses look like. So the expansion of the ARCH program into Emerge, we've been working Emerge since September of 2018. So the proposed pathway and goals for that aspect was patient would be seen in the emergency department with an opiate overdose, withdrawal, or other addiction-related complication. Patient would be identified as at risk by either the emergency department staff or the bedside emergency department staff or the ARCH RN. And then ARCH would be consulted, and the patient would be either transferred to the ARCH clinic that we have. It's also at the Royal Alexandra Hospital as soon as medically cleared, and then that would just get them out of the emergency department to decrease length of stay. The proposed goals would be to give over 80% of patients who needed a naloxone kit. Opioid agonist treatment would be initiated in the ED with immediate clinic follow-up, and then the ARCH clinic bridges people into a community opioid agonist treatment program. And then counseling regarding opioid agonist treatment for over 80% of people who are eligible. So like I said, started in September. The main team consists of a registered nurse, a peer support worker, and the ARCH MD. But the full ARCH team with addiction counselors, social workers, and everybody is available if we do a formal ARCH consult. That would be a physician-to-physician consult. The peer support and the ARCH MD currently are only available Monday to Friday from 8 a.m. to 1600, but we're working on expanding those hours. And then there's an RN 7 days a week from 7 a.m. to 2300 or 11 p.m. One of the things we have run into that's a little bit tricky is we can't bypass the triage process. ARCH we don't have a unit in the hospital, it's a consultation service, so patients still need to go through the full emergency triage process and be seen by an emergency physician before the full ARCH team would see them. The RNs and peer support workers can see them before that, but so the reasoning behind that too is that somebody could come in looking like they're in withdrawal, but they could have something else going on, so we do really need to have them checked out by the triage nurse and the emergency physician. And then our main goal is to start opioid agonist treatment in the emergency department by the MD with immediate follow-up or transfer to our clinic for community bridging. So the RHRN, these are kind of the role that we can do. So again, assisting with providing information on opioid agonist therapy to both patients and emergency staff, advocate for and suggesting formal ARCH consults when necessary, providing information on anti-craving meds for patients with an alcohol use disorder. We can provide information on community resources, including the community supervised consumption sites. We provide and can obtain a consent for the supervised consumption service at the Royal Alexandra Hospital, engaging patients early in the triage process. So often we'll just go and see patients in the waiting room, especially if we know that they're at a risk for leaving without being seen, or if they've left without treatment in the past. We'll just kind of engage them and just say, like, we're here and there's someone that will help you. You need to just stick it out and please stay, and we'll just distribute harm reduction supplies and take-home naloxone kits or overdose response kits as well in the waiting room, so that if someone can't stay or is in too bad a withdrawal and is going to leave, at least they're a little bit safer about their use. We can book the transitional clinic appointments for patients who are started on opioid agonist therapy for immediate follow-up and bridging to the community programs. And we also book clinic appointments for patients who are socially unstable and also have addictions issues. So even if they're not with an opioid use disorder, they have like an alcohol use disorder, or other addiction issues, and then like no primary care physician or no stable housing or no income support. We also will see those patients in the clinic to try and bridge them to community resources in that respect as well. Our peer support workers are amazing. I don't know what we'd do without them. So they're great. So I see Rob. He's not with us anymore, but so they also engage patients early in the triage process, sit with patients in the waiting room, provide emotional support, relationship building, assist with providing information on community resources. We have an ID program at the Royal Alexandra Hospital, so helping with that, financial supports, and acting as bridge between patients and staff, so really advocating for those patients. Provide distractions like coloring books and pencils, and provide clothing and toiletries. So our two peer support workers at the Alex, I asked them to kind of give me a little blurb about what they feel like their biggest role is. So this is what they came up with. So he said, the biggest role we play in Emerge is with lived experience. Having been where our people who are ARCH people we visit, we are asked to see, then we can use our stories to build a relationship and build an understanding. We then are able to utilize that to develop a trust to address basic needs like hunger, pain, and sometimes just being heard, or a simple thing like wanting another blanket. So I just think, yeah, it's great to have them, and really highlights like how much of an advocate they are, and just like the simple comforts, like just bringing people water or a blanket while they're waiting in emergency for 6 hours can make a huge difference, whether that person's going to stay or not. The ARCH-MD can assist the emergency physician in prescribing buprenorphine and naloxone. They start patients on methadone. Again, the methadone exemption is a little bit more complicated than prescribing buprenorphine and naloxone. So right now, it's pretty much just ARCH physicians that do start the methadone. There's a few emergency physicians that do it, but and then the assistant treatment of complicated intoxication and withdrawal. This can include trying to advocate for an inpatient complex medical detox admission. Right now, all our CMD admissions go through the medicine team, so we can try to advocate, but not guaranteed. And they assist our RN to book follow-up appointments in the clinic, and can book immediate follow-up appointments actually directly at some of the community clinics, which the nurses can't do. So kind of bypass the transitional clinic sometimes, depending on the time of day and things like that. So our clinic is open from 8 a.m. to 1600 Monday to Friday. It's an NP-led multidisciplinary clinic. So there's social workers, peer support workers, addiction counselors, and then the ArchMD is also available. The priority patients, again, are those with opioid use disorder needing initiation, titration, or bridge of opioid agonist treatment. And then we also will see patients with other substance use disorders, with social instability, patients with high-risk withdrawal. And if you've been an ARCH patient in the past, sometimes we'll be able to make an appointment or a walk-in for you if you called the clinic. Patients that present to the emergency with substance use disorder but do have like a primary care and are socially stable, usually we just, the ARCH-RN goes to see those patients and helps the ED nurse and the physician to navigate more like appropriate community supports and assessment. And then sometimes we'll still refer to the clinic, but usually if you're socially stable, we can usually find something, a community support that's more, it'd be faster to get into the community supports anyway. So this is just kind of like a synopsis of ARCH and what we do. So how are we doing since September? So these are some stats from before and after the emergency opened. So our number of consults for withdrawal management prior to the opening of the, having a dedicated ARCH-RN and MD in emergency, we had 105 consults coming from Emerge, and now there's 187 since September. 20 for pain management is 22 consults, and then since September 43. Intoxication management 2 and now 7. So those ones are a little bit less, but the biggest thing was the withdrawal and pain management. We've been seeing a lot more ER referred consults since being down there, and then opioid agonist treatment interventions for ER referred consults. So this would be for counseling related to opioid agonist treatment, we had 31 prior to us being in emergency, and now 86. For buprenorphine starts went from 29 to 72. Methadone starts 26 to 34. Maintaining on current opioid agonist treatment 17 to 33. And then the others were a little bit less. And then ARCH clinic appointments booked. So we did have a small ARCH clinic as well prior to prior to us being in Emerge, but it was like located in the community service center and very difficult to get to. Now it's right in the main hospital. So prior to the ARCH team being in emergency, we had 427 appointments between April and September of 2018, and the show rate was only 31%. And since we've been in Emerge now, we had 896 appointments booked with like 63% coming. So I think that's quite good. Before it was kind of like, even when you had an appointment, it's very rare that someone would show up, and now people are actually coming and engaging, so it's great. And then new consults received from the ER where the intake was completed in the clinic, so that would be, just basically clinic appointments kind of booked from the ED. So 32 consults between April and September of 2018, and then 111 after we were in Emerge. And that's all I have. Or new questions after. So these are just some extra, like, I don't know if you're interested, but very interesting TED Talks. So the first one is Everything You Think You Know About Addiction Is Wrong by Johan Hari, and it kind of goes over like Portugal decriminalized all their drugs, and it talks about also the social stability being a very big impactor on addiction. It's a very interesting TED Talk. And then the other one is called The Harm Reduction Model of Drug Addiction Treatment by Mark Tyndall. I also brought just some supplies from the SCS. I don't know, just to kind of show what we do have available. So we do have like sterile cookers for people to use to prepare their drugs, and we do have like condoms and dental dams now and lubricant. So, and outpatients can access our site for supplies. So if you ever do have anyone you need to that needs supplies or something, that's another place you can send them as well.
Thanks very much. I know that CEASE is a small community organization. We've referred many to Arch, and over the years, it's just becoming richer and more grounded, and I think the stats show the difference being in the Emerge department, so we love Arch. Now, if you have any questions, I think if you could just pass them down the row and the other end. Oh, either end, and to Chris and to Lycia, sorry. And then they'll bring them up to me, and then we'll ask our two wonderful presenters to respond. This just makes it easier for anyone listening at home or in their office than rather having questions from the floor without a mic. Is there one question to start with? All right, this is the lucky one, the first question. Are both of the services talked about today for youth as well as adults? So, yeah. Pull the mic. Pulling the mic out here.
So with Access 24/7, we definitely won't say no to someone who walks in that's under 18 years old. We don't have access within our services to book into places for some of our youth and child programming, but we would basically, if a family walked in and they were worried about a youth or a child, we would bring up the service on a conference call and kind of help them walk through that process. So our staff will be equipped to work with that clientele, but we don't have the access to that service, so we're going to try our best to make sure it's a smooth transition.
And just unfortunately right now, Arch is just for the adult population. We don't have any pediatrics that we see. We just really try to work with getting those patients transferred to the U of A where the stollery is, and working with that. That being said, the all-time, if we do have minors, they can still access our supervised consumption service at the Alex if they qualify as like a mature minor, and we have the consent process and things like that. But otherwise, it's just adult population.
Thanks. Do only people in withdrawal access Arch?
No. So pretty much, if we kind of, so Arch is kind of like as a consult service for more of the complicated cases, so more complex withdrawal or complex substance usage issues, or people who have also social destabilization. But we'll see patients with any sort of addiction issue at all. We get lots of consults for people who aren't in withdrawal. So even just people who come in with like an abscess from injection drug use, or just don't have a family doctor, but also have an addiction issue, things like that too.
Thank you. Can someone get referral to ongoing psychiatric care from Access 24/7?
Yes. Ongoing access to psychiatric care, ongoing access to mental health therapists, addiction counseling, peer support, many of the groups eventually. I think we offer over 170 different group programs within Alberta Health Services, addiction and mental health. And as we progress through this transformation, someone calling access can get in directly to one of our groups that way. So access to everything that we offer.
That's very good news. How can people access free, that's the emphasis on the word here, free trauma counseling for addicted people and ex-convicts?
Very good question. I think when access, right now, if you wanted to try and access services for someone that is presenting with those needs, I would call 780-342-7600. When we are actually open and have launched, we'll have one phone number. Basically, anyone can call with their concerns, and then we'll help them access the service that they need.
Can you tell us the cost for methadone or Suboxone treatment that is not covered? And like, what if you really can't afford it?
So I don't know the cost offhand. I could definitely find that out if my email is up at the top there. So if you want to even email me and then I'll have your email, I can get the definite cost. But a lot of people do say it's less than buying illicit, at least they're happy to pay it. But yeah, if you don't have drug coverage, we do work closely with people. We wouldn't start something that they aren't able to pay for, and that's just unfortunately the way of the system right now.
Thanks. This question could maybe be answered by both of you in different ways. What will it look like when a client in crisis walks in the door requiring inpatient care?
I can answer that one from the access perspective. So let's say Megan walks into Access 24/7 and it looks like you're experiencing some psychosis and maybe some other underlying features that basically the therapist has assessed that you're either a risk to yourself or those in the community. So what would happen next is you would be seen by our psychiatrist. If it was between the hours of, I think it's 8 to 8, we'll have psychiatrist. And then basically there would be an assessment done to see whether or not you would meet criteria under the Mental Health Act to be brought to hospital. And then we have a coordinated system called RAPID, and that's basically a communication center that covers the entire province. So we would call into that number, they would link us to the receiving site where we would have you going, and then that would link the communication between the healthcare provider in the community with the receiving emergency department to make sure that that transition happens. What one concern is from the Royal Alex site around, will this increase the volumes of patients that come to Anderson Hall? Will they go straight to the Royal Alex Hospital if they need admission? But that's why we have this coordinated access through this RAPID group. For the patient, it will totally depend on whether or not there are staff available potentially to transport that person safely, or if we call EMS or one of our other partners, if that makes sense. So.
Yeah, I could just speak, I guess, from like a Royal Alex perspective. If somebody came in with like acute withdrawal or needing ARCH imminently, so they'll go through the triage process. Unfortunately, they're usually still triaged fairly low. So we'll kind of see them in the waiting room, the RN talk to them a little bit, or the peer support worker, and kind of encourage them to wait it out and let them know they'll get help. If it's between 8 and 4, there is an ARCH MD, so they can. Once they're seen by an emergency physician, the emergency physician, if they feel it's necessary, can consult the ARCH physician, or we can just see them as the RN and kind of provide guidance for the emergency physician. So if they do decide to do a full ARCH consult, there is a physician available dedicated to emerge from 8 to 4. And then there's actually another ARCH physician that covers inpatient that will also cover emerge till 9. And then if it's outside of those hours, and outside of an ARCH RN seeing them, the physician will just kind of do their best in will do like symptom management versus if the emergency physician isn't comfortable starting buprenorphine, naloxone or something on that patient, they'll just do symptom management and they'll book them into an ARCH clinic appointment for the next day. Because the emergency physicians also have access to booking our clinic appointments overnight. And I guess the other thing I just thought of too, someone had asked about who else we see. So if someone does come in with, like, let's say COPD, but then they also have an addiction issue, and they're like, let's say they have a opioid use disorder, but their primary concern right now is like their COPD. ARCH will see them to also still talk to them about whether they are in withdrawal and whether they'd like to start opioid agonist treatment while they're in the hospital and things like that too.
Thank you. Can either program help with referral to a treatment program?
Yes, we'll have, if you're looking for addictions treatment, any of our clinicians would be able to help with that, but we have made sure that our staffing includes one addiction counselor, at least one addiction counselor 24/7.
Yeah, and we have social workers and addictions counselors that also bridge to long-term treatment and housing as well.
Thank you. Are there plans for community advocacy to reduce societal stigma around addictions and mental health? I think that's part of what we're engaging in right now. So what more might we envision?
You go first. I have to think about that.
That's a hard one.
That is a very hard one, yeah.
Yeah, I mean, that's our goal and dream of the programs, but yeah, I think just coming and talking, I know like Dr. Dong, the director of ARCH, does a lot of community outreach and engagement and just talking at things like this and talking with the city and yeah, really trying to work with all stakeholders to see what we can do to decrease stigma and yeah.
Yeah. And for us, I think it's been kind of a breaking point in the healthcare system where we finally feel like mental health and addictions is being recognized as something that's important to address. So that being said, by allowing for expansion of programming and services, et cetera, I think the advocacy groups are still very important. So yeah, I would encourage people to get involved if they're really passionate about it, because there's definitely ways to make a difference.
Well, and when I think about before ARCH and since ARCH and, you know, before Access 24/7 and we'll be living this new experience, I think any of us involved in community or law enforcement or as family members or persons struggling, I think we're seeing the change and you know, all that great evidence and research that is happening and that's building these pathways, that's going to make a difference, and then it gives all of us a way to go out and talk about it more, whether it's with family members or, you know, professionally, and to say, look at how we are changing this together and listening to people's experiences. So thank you. Will preventative research practices be done in the future? It's a little bit tricky. Will preventative research, so I guess that would be preventing people from experiencing mental health challenges and addictions. Will preventative research practices be done in the future?
So I think within addiction and mental health, we have a very robust evaluation and research portfolio that works really closely with the Faculty of Medicine as well as the Faculty of Public Health. So we are working, I don't know what specifically we've done so far, but that is something in the works, as well as with Alberta Innovates.
Yeah, I think we also have our research team, which I'm sure is also doing, like, I don't know specific initiatives, but I know like there's a lot of focus on prevention right now. So yeah, I think so.
Well, and maybe that's something that all of us can be involved in, because it's, you know, creating that safety and also making really good referrals that helps. Do both programs help with making sure clients have a safe place to go when they leave? Like, what's the bridge back into the community, whether it's a shelter or other forms of housing along the continuum?
Right. So at Access 24/7, one of the things that the clinicians will be assessing is I guess the risks to that individual if they were to walk out the doors, and what does housing look like. So that's where we're really hoping to work with our community partners and trying to figure out to provide that piece, that essential piece, the housing piece. And then we also have housing services available within the continuum of addiction and mental health. So we work really closely with them as well. And we might actually have someone on site that would specifically look at some of those housing needs.
Yeah, and that's like one of the a huge role for our social workers within the ARCH team. So the unit social workers kind of don't often have a lot of access or time to link people with long-term housing, so often people will just be discharged to shelter. That's kind of the only option. So that's one of the things we try to book people back into our clinic for, is to get a more long-term housing solution. And we've seen just, especially with our injectable opioid agonist therapy patients, we've seen like a huge impact on housing. So really, especially with discharging those, we've seen a incredibly fast destabilization if we've discharged to a shelter environment or things like that. So really trying to work with physicians in the hospital and trying to get people to very stable housing before discharge is one of our big roles and things and advocacy things we're working on. Yeah.
Thank you. Is anybody from E4C here? Oh, great. There she is, Pam Schellenberg in the housing area. I just want to celebrate again a unique partnership between Alberta Health Services and E4C, which is bringing together kind of the best of community and health supports with a whole range of housing programs. And it's narrowing that gap because, again, those of us working in community and policing, we've seen what happens, that destabilization. People get healthy in the hospital, stable, and then they're released into nothingness and everything begins again. Pam, I'm just going to put you on the spot and ask you to come up for a moment and just say one word, a few words about the different types of housing through this unique partnership, which I feel is a real sign of hope. Plus, Alberta Health Services itself has created some other housing partnerships, like with Spady and some of their own housing programs, so I feel hopeful.
Do you want to repeat your question one more time?
Do these two programs help with making sure clients have a safe place to go when they leave, e.g. WEAC, Women's Emergency Accommodation Shelter, and other housing? And what I was really celebrating was the fact that it's a partnership between Alberta Health Services and a community organization, co-locating staff and all that.
So I'm hoping I can speak to this because I don't oversee the Interways programs and I am somewhat new to E4C. But I know definitely that these programs support, I oversee WEAC, so I know that these programs really support the ladies that we've got within WEAC, especially some of the challenges that they're experiencing. We send a lot of people over, they access the ARCH program over at the Royal Alex, and we're really looking forward to the Access 24/7 to see how that can support the ladies that we've got. But also in terms of the Interways transitional housing programming and that type of thing, I think the partnership has really brought forward the need for that holistic type of supports around these individuals so that when they are coming out of these types of programs or they are getting back into the community, as you guys mentioned, kind of that deterioration often when they get released into shelter, I think it provides that stability to be able to have all of those individuals working together. And I think as well from kind of a community of practice perspective, it provides a lot of learning and a lot of opportunities for the staffing to be able to support each other, both AHS to community and community to AHS. So that would be my reflection on it.
Well done, and thanks for letting me put you on the spot there. Are there any other unique partnerships that we might want to just celebrate that we didn't touch on today? Because we wanted this session, we're going into the springtime. often there's a lot of sorrow and heaviness, and we run into system barriers in all of our work. And we wanted to have a celebration about really the great initiatives in Alberta Health Services, community, and law enforcement working together. So if anyone has anything else they think would really help everyone here to know about, please come forward and take the mic.
I think a piece that really connects with Megan and Kim's work, is the work of the Minister's Opioid Response Commission. And because an election has been called, that work will be on hold, but it's a great website to check out for the most up-to-date recommendations and work that has moved forward, including community grants that assist our communities. In particular, Boyle Street Community Services has a youth team working with youth on harm reduction and opioids in the community. But also, just yesterday, they released their most recent opioid surveillance report. And with the last two reports, they've done an infographic that really demonstrates quite well the expansion of some of the treatment programs throughout Alberta, and just what a really good snapshot of the current picture in our province. And I think our province has done quite well considering all the challenges for folks. And we've kind of moved away from a really reactive situation with the opioids to more of a responsive situation, and I really want to thank our speakers for that today. But just a reminder, check it out. It's really good information, and it gives you a really good picture of all the work being done here in Alberta. So, thank you.
Thanks. Dorian is with the City of Edmonton Citizen Services and has been working on a number of initiatives and heavy users of services, which is also another unique coordinated response. So I think it's really important. And it is 1:27. I would like to ask for a big round of applause for Kimberly and for Megan. And to know that they represent huge teams behind them. And so we want to give thanks for all of those people who are part of the teams and creating this response. And to all of you for coming out to this Lunch and Learn. We will be having our Sexual Exploitation Week of Awareness. It'll be the last week of May. We hope to have 2 webinars during that week. Our mayor will be, I don't know if the mayor will be proclaiming, but we will be proclaiming a week of awareness May the 27th, and we'll continue to build this community knowledge. So thank you all very much for coming, and thanks to our team for webcasting, and we'll see you again. Bye.